All right, let's dive in. Today, we're going to tackle a classic, high-stakes challenge that you'll see in pretty much any emergency department, a patient with a lower GI bleed. We're going to use a clinical case to build a really practical framework so you'll know exactly how to think it through. So picture it. You walk into the room, and this is the scene. It happened out of nowhere, there's a lot of blood, and the patient, well, he's obviously pretty worried. This is a moment where having a structured approach is absolutely everything. So where do you even start?
Okay, we're going to use this case as our roadmap. We'll break down the challenge piece by piece to build a solid diagnostic framework. But first things first, what exactly are we dealing with here?
So, lower GI bleeding, or LGIB for short, is really just defined by its anatomy. We're talking about any bleeding that starts distal to the ligament of Treitz. Now, that technically includes the small bowel, but let's be real, the vast majority of these cases, and our main focus, are coming from the colon.
Now let's talk about clinical overlap, because this is a huge diagnostic pitfall. Typically we think bright red blood, hematochezia, that's a lower GI source. And black, tarry stools, melena, that points to an upper GI source. But, and this is a massive clinical trap, a really big upper GI bleed can move through the system so fast that it comes out looking like red blood. And on the flip side, a slow bleed from the right side of the colon can take its time and turn black. So you always have to keep both possibilities on your radar.
3Here's something that might actually surprise you. The whole landscape of GI bleeding is changing. Thanks to things like proton pump inhibitors and getting rid of H. pylori, the rates of upper GI bleeds have dropped like a rock. And the result? Hospitalizations for lower GI bleeds are now just about as common. This is a problem we're seeing more and more of.
Okay, so with that background, let's start building our foundation. How in the world do we organize the dozens of possible causes into something that's actually manageable at the bedside?
The key, really, is to think in categories. Pretty much every cause of a lower GI bleed can be sorted into one of these 4 buckets: anatomic, vascular, inflammatory, or neoplastic. This is the mental scaffolding we're going to use to solve our case.
And you can see how this framework is actually used in the literature. Now you might notice something interesting here. Diverticulosis is listed under vascular. You might think, wait, isn't that an anatomic problem? And you're right, the diverticulum itself is an anatomic defect. But the bleeding? That comes from a tiny artery at its base, which is a vascular event. You'll see it classified both ways, which just goes to show how these categories can overlap a bit, but the framework itself is still a super powerful tool.
So, let's get back to our patient, our 68-year-old guy. Which one of these categories best fits his story?
Just think about the key features again. He's older, the bleeding was abrupt, it was a lot of blood, and, this is really important, he didn't have any pain. That combination of symptoms is a classic pattern, and it points overwhelmingly to one specific diagnosis.
And yeah, that diagnosis is diverticulosis. It accounts for up to 55% of all major lower GI bleeds. Statistically speaking, for a presentation like this, it's gotta be at the top of your list.
So why is the presentation so dramatic? It's because the bleeding is arterial. You see, diverticula tend to form right where arteries poke through the colon wall, and that makes these vessels really vulnerable. The good news, though, is that the bleeding often stops on its own, something like 80% of the time. Key risk factors? Think old age and using things like NSAIDs or aspirin, which can really irritate those fragile vessels.
Okay, now here is a fantastic clinical pearl. Most diverticula, those little outpouchings, are actually on the left side of the colon. But, weirdly, when they decide to bleed, it's the ones on the right side that are the culprit 50 to 90% of the time. The thinking is that the right-sided ones have wider necks, which exposes the blood vessel inside to more wear and tear.
So, painless bleeding points us in one direction. But what if the story was different? What if our patient also had pain?
Let's just change the scenario a bit. Same patient, same ER, but this time he comes in with cramping abdominal pain and bloody diarrhea. Well, this completely changes our differential diagnosis. It points us toward a totally different category of causes.
When you have pain and diarrhea, that's the classic sign of colitis, inflammation of the colon. This is our inflammatory bucket. Now, the bleeding here is usually a lot milder because it's coming from an inflamed, oozing surface, not a big ruptured artery. This is an umbrella term that includes things like infectious colitis, ischemic colitis, especially in older folks with vascular issues, and of course, inflammatory bowel disease like ulcerative colitis or Crohn's.
All right, so we've covered our #1 anatomic cause, diverticulosis, and our main inflammatory causes, the colitis. Now let's quickly hit on a few other key players from our vascular and neoplastic categories.
This table breaks down 3 other really crucial causes. First, angiodysplasia. These are basically just fragile, dilated blood vessels, really common in the elderly or in patients with kidney disease. The bleeding is typically painless and venous, which means it's way less dramatic than a diverticular bleed. Often, it's just small, recurrent episodes. Next up, colorectal cancer, which always has to be on your radar in older patients. This tends to cause a chronic, low-grade bleed that you might only find because a patient is anemic. And finally, hemorrhoids. Look, they're incredibly common, especially in younger folks, and they cause that minor, bright red bleeding that just coats the stool.
But here is maybe the most important point about hemorrhoids. Just because you see them on an exam, you can never assume they're the source of any significant bleeding until you have ruled out something more serious higher up in the colon. It is a classic and dangerous trap to fall into.
So let's put this all together. How do you walk into that room and confidently work through all these possibilities in real time?
It really all boils down to 3 simple questions you should be asking yourself at the bedside. Question 1, is there pain? Pain means inflammation, colitis. No pain points you toward a structural or vascular cause. Question 2, what's the volume? Is it massive, arterial-type bleeding that just screams diverticulosis? If it's mild or chronic, you think about other things. And question 3, how old is the patient? Age is such a powerful filter that dramatically shifts your probabilities.
You see, this is all about pattern recognition. These are the illness scripts you want burned into your brain. Painless plus massive bleeding, that's diverticulosis until proven otherwise. Pain plus diarrhea, that's colitis. Painless and recurrent, think angiodysplasia. And chronic bleeding with anemia should always make you think about cancer.
Ultimately, your whole approach to any lower GI bleed can be summed up with this mantra. Classify the cause using your 4 categories, localize the potential source based on the clinical clues you find, and then prioritize your workup based on what's most likely and what's most dangerous.
And really, that's it. By starting with a simple framework and learning these key patterns, you can turn what seems like a chaotic presentation into an ordered, logical problem. So next time you see hematochezia in the ER, you don't have to panic. You'll know exactly how to think it through.